So good morning, guys. So just like last time, today also we are going to talk about some of the clinical problems. Now, please focus here, all of you. Okay, let's try to solve this problem. A 55-year-old man presents to a physician with jaundice. So this is a case of jaundice, and the person is 55-year-old. Ultrasonography demonstrates a 5 centimeter mass in the head of the pancreas. So the ultrasound has already given us the diagnosis here. If a person relatively older, not that old, I should say middle-aged person actually, with a mass in the head of the pancreas with jaundice, most probably this is a case of carcinoma of the head of the pancreas. Okay, carcinoma of the head of the pancreas. Now, endoscopic retrograde cholangiopancreatography or ERCP was done, and it shows large hypertrophic chromatic nuclei and a high nuclear cytoplasmic ratio. So actually ERCP took some cytologic sampling, okay, from that area, and it was evaluated, and it shows a clear-cut finding. So what type of cells are these? Yes,
Malignant cell.
very good. These are the malignant cells, okay. These are very hallmark of malignant cell, hyperchromatic nuclei and high nuclear cytoplasmic ratio. A few small glands composed of these cells are also seen in the cytologic preparation. The overall prognosis for this man will be most similar to that of patient with which of the following malignancy. Now see that this is a slightly difficult question. They have not asked us the diagnosis. They have asked about the prognosis, and that prognosis also we have to compare with similar type of another malignancy. So first is diagnosis you have to make. Diagnosis is carcinoma of the head of the pancreas or adenocarcinoma of pancreas. So my second thinking should be which one of these cancer has got the worst prognosis, okay, so that I can pick the right answer, because carcinoma of pancreas is one of the poorest cancer to have. It has the worst prognosis, okay, one of the cancer to have worst prognosis, I should say. See this: adenocarcinoma of the breast, adenocarcinoma of colon, adenocarcinoma of esophagus, adenocarcinoma of the prostate, and primary gastric lymphoma. Anyone? What is the answer?
The adenocarcinoma of the esophagus.
Adenocarcinoma of the esophagus. Why? Can you give me reason?
Sir, among these malignancies, the adenocarcinoma of esophagus got the worst prognosis, and also the carcinoma of the head of the pancreas having worse prognosis.
He is absolutely right. Okay, so this is a bit of difficult question. You should have a good knowledge, then only you can answer this. But listen carefully. Let's utilize the time here. Carcinoma of the esophagus has a very poor prognosis because this type of patient present quite late to the hospital. They don't come early. They are confused with something else, the clinical features. And this is the one of the poorest cancer to have, just like adenocarcinoma of the pancreas. Now let's talk about the explanation, okay? Then it is very clear to you. The correct answer is C. The patient probably has pancreatic adenocarcinoma. This cancer carries one of the worst prognosis with 3.5% overall 5-year survival rate. This is a very, very low percentage, despite all attempts at aggressive management. The prognosis is also bleak with adenocarcinoma of the esophagus, which has around 10% overall 5-year survival rate. So that's why this is a correct answer here. Other options: adenocarcinoma of the breast now has 5-year survival rate of 60 to 70%. Colon 50 to 60%, prostate 50 to 70%, and primary gastric lymphoma has 75 to 85%. Okay, that's why we have chosen that as a correct answer. Now, let's utilize time. Let's talk a little bit about carcinoma of the head of the pancreas. Listen, this is the cancer which causes obstruction to the common bile duct. So it presents as obstructive jaundice. And you all know the features of obstructive jaundice. The person is quite itchy. Okay, there is a very deep jaundice, and the person passes yellow colored urine as well as clay colored stool. Okay, very deep jaundice, itchy sensation on the skin, and sometimes even the scratch marks, clay colored stool, very high colored urine. These are the typical features of obstructive jaundice. One other feature of pancreatic adenocarcinoma is called Trussell sign. What is Trussell sign? Anybody?
This is
Enlargement of cervical node.
no, this is migratory thrombophlebitis. There is a inflammation of superficial vein, which is migratory.
Okay. Now this is the migratory thrombophlebitis or superficial migratory thrombophlebitis. This is one of the typical features of pancreatic adenocarcinoma, which may be asked in another question in your exam. Okay, that's why I'm involving it here. Now, you are quite easily confused this with Troisier sign. See this? Let me write that also here, so that there will be no confusion after this. Troisier sign. Now, what is this Troisier sign? Anybody? This Troisier sign is the enlargement of left supraclavicular lymph node, which occurs because of intra-abdominal malignancy. Okay, this is also known as Virchow node, and this sign is called Troisier sign, Trussell sign. Okay, they sound a bit similar. That's why a bit of confusion exists. But please make sure the spelling here, okay, and give the correct answer. Let's move on. I'd like to share some of the points here. Now, what is the surgery you do in case of pancreatic adenocarcinoma? What is the name of that surgery? Anybody?
Good procedure, sir.
Whipple's procedure.
Whipple surgery.
Exactly. Whipple surgery or Whipple's procedure. That can also be asked in your exam. Whipple's procedure. This is a very, complicated type of surgery where common bile duct is, removed. The part of common bile duct, I mean, duodenum is removed. Okay, distal part of the stomach is removed, and the affected area of the pancreas is also removed, followed by reconstruction surgery. Now, let's move on. Now, let's see the number 2. Please mute yourself. Otherwise, I have to mute all of you because it is causing a bit of problem. Now, question number 2. This is a 10-year-old boy with a history of epilepsy and mental retardation. Very clear-cut case. 10-year-old boy with a history of epilepsy or seizure disorder and mental retardation is brought to the specialty clinic for evaluation. Physical examination is remarkable for several ovoid hypopigmented areas on the trunk and large number of red and yellow papules on the face, particularly near the mouth. So these are the physical findings in this boy. Biopsy of the papule demonstrates they are a type of angiofibromata. Okay, they are a type of angiofibromata, multiple angiofibroma together. This patient is most likely to have which of the following central nervous system pathology? So the answers provided are, or the options are acoustic neuroma, capillary hemangioblastoma, herniation of cerebellar tonsils into the foramen magnum, tuberous sclerosis, and leptomeningeal angiomatosis. Now, anybody wants to,
Tuberous sclerosis.
Okay, tuberous
Sclerosis.
Tuberous sclerosis.
Okay, can you explain why tuberous sclerosis?
Because of a hypopigmented area on the trunk and mouth, and papule on the face.
Okay. Fine. Any other student?
And also mental
Sir,
retarded in epilepsy.
Good, Khatir. Good point you have mentioned. Yes. Anybody else?
sir, the patient is child with epilepsy and mental retardation, so it's pointing toward the central nervous system abnormality. On physical examination, the patient is having several old hypopigmented areas on trunk. So most probably these are the ash leaf spots.
Mm-hmm.
And
Good.
also the ear red and yellow papules on face. So most probably these are the adenoma sebaceum.
Good. Good.
So all these findings, skin findings in sentinel system findings seen in tuberous sclerosis.
Very good. Okay. Both of the students are answering quite properly here, but so many other students are listening to this discussion. So let me explain it. Okay. Very good answer. That's the correct answer. This is a case of tuberous sclerosis. Now, tuberous sclerosis is autosomal dominant disorder. So it runs in the family at autosomal dominant inheritance. That means there is a 50% chance of occurrence in each pregnancy. That is the first thing. It commonly presents as a seizure disorder or epilepsy. This is an intractable type of epilepsy, very difficult to treat. We keep on changing the medicine, the anti-epileptic drugs. We keep on adding it, but still the seizure may not be controlled. And another, there is a mental retardation. The IQ level is very poor. According to the definition, mental retardation is when IQ level is less than 70. Okay. The hallmark of this, why we made this type of diagnosis, there are two important clues given to you. One is called ash leaf spot, is right? This is called ash leaf spot. Several ovoid hypopigmented areas on the trunk near to the axilla. These are ash leaf spot. And red and yellow papules on the face. These are called adenoma sebaceum. Now, this adenoma sebaceum, sometimes we are confused with pimples, but actually they are not pimple. They are type of angiofibroma. Okay, these are the hallmarks of tuberous sclerosis. This tuberous sclerosis also has some affection in other organ. In the heart, it can cause one pathology. What is the name of that pathology in the heart? Anyone? In the heart.
Atrial myxoma.
Okay. This is known as rhabdomyoma. This is known as rhabdomyoma in the heart. Okay. It is another type of tumor, a tumor-like condition, you can say, a bit similar to atrial myxoma. Myxoma is the commonest tumor which is present in the heart. So similar type of differential diagnosis is known as rhabdomyoma, which is seen in tuberous sclerosis. In the kidney also, there are tumors present. A small mass can occur in the kidney also. So some important information about tuberous sclerosis. Now, acoustic neuroma. Okay, acoustic neuroma is the tumor which is connected with eighth nerve. You must have studied in ENT. This is the tumor which is associated with eighth nerve or vestibulocochlear nerve, and it is very strongly connected with neurofibromatosis type 2. Neurofibromatosis type 2. So never forget this, very, very important question in the exam. Capillary hemangioblastoma, this option 2, is present in von Hippel-Lindau syndrome. Von Hippel-Lindau syndrome. And renal cell carcinoma is commonly associated with von Hippel-Lindau disease. It doesn't present like that, so it is easily excluded here. C, herniation of cerebellar tonsil into the foramen magnum is called Arnold-Chiari malformation. Okay, Arnold-Chiari malformation, and there are different types. Type 1, type 2, and even type 3 is explained in the different textbook. But type 1 and type 2 are the major one. Okay, the patient may present with imbalance patient may present with hydrocephalus and all the features of raised ICP. One important point I like to highlight, in the next slide, all these explanations are given. In type 2 Arnold-Chiari malformation, there is spina bifida. There is a, spina bifida is commonly associated, like myelomeningocele. Myelomeningocele is a type of spina bifida. So Arnold-Chiari malformation type 2 is strongly associated with that. And the last one is a leptomeningeal angiomatosis. This is a wrong answer here because this is seen in Sturge-Weber syndrome. Sturge-Weber syndrome, where port wine stain is very commonly seen. Now, let us show you all the explanation in the next slide. Okay, let's quickly go through it. I already told you, knowing the correct answer is not enough. You need to give certain explanations here. So we already talked about tuberous sclerosis. Okay, please go through this. But other features, let me repeat again. Acoustic neuroma are a feature of neurofibromatosis type 2. This is not a case. Capillary hemangioblastoma are a feature of von Hippel-Lindau syndrome, von Hippel-Lindau disease. Herniation of cerebellar tonsil is a feature of Arnold-Chiari malformation. These are, mainly of two types. Type 1 is associated with herniation of cerebellar tonsil, and type 2, along with that, it is also associated with spina bifida, that is myelomeningocele. And the last one is a feature of Sturge-Weber disease or syndrome. It is strongly connected with port wine stain. Let me write that term here, port wine stain, because who knows, this question may be asked in your next exam. Port wine stain on the face. It looks a bit of pinkish, color on the face, very typical. Maybe on the forehead, maybe on the around the eyeball or on the cheek. Along with that, it also presents with epilepsy, and it has got leptomeningeal angiomatosis in the brain. Means brain is affected here. So these are some of the important information regarding this type of case. Let's move on. Now, see there, number 3. This is a 30-year-old African American woman who has a chest X-ray that shows hilar lymphadenopathy and diffuse abnormalities of the lung parenchyma. Now, with this description itself, a student who has studied this topic before can think about the diagnosis, but still, it has been made easy for you. Biopsy reveals non-caseating granuloma, acid-fast stain, silver stain, and PAS stain, per iodic acid Schiff stain on the granuloma are negative. Which of the following is the most likely diagnosis? Is it coccidioidomycosis? Is it histoplasmosis? Is it leprosy? Is it sarcoidosis? Or is it tuberculosis? Anybody?
Sarcoidosis.
This is sarcoidosis. Okay. Please give me explanation. Anybody?
Sir, here, sir, we having chest X-ray, and the patient is 30-year-old female, which is the race is also important. So sarcoidosis is most common in African and European.
Good.
And here in X-ray they showed their hilar lymphadenopathy, and they also said about the biopsy that is non-caseating granuloma.
Okay.
And they have also have done some tests such as acid-fast stain, which is for tuberculosis, and also silver test, which is for fungal infection. They are negative, so most probably there is only one option, that is sarcoidosis.
Very good. He has given the complete explanation here. Okay. So see there, a lot of clues are already provided. She's a female. Sarcoidosis is more common, and the race is important here. He's right. African American people commonly develop sarcoidosis, and it commonly presents like this. bilateral hilar lymphadenopathy, and a diffuse lung parenchymal involvement. And biopsy is an important clue. This is a case of non-caseating granuloma. Yes, we have studied this. This is an example of granulomatous inflammation. Now, these stain are done to rule out other pathologies or other infection like acid fast, which is seen in mycobacterial involvement. Silver and PS stain are mainly done for fungal, to rule out the fungal diseases. So we can easily rule out coccidioidomycosis. This is an example of dimorphic fungi. Histoplasmosis is also dimorphic fungi, ruled out. Leprosy, mycobacteria, ruled out. Tuberculosis is also mycobacteria. So only one option is left, that is sarcoidosis. So this is the way you can easily solve this question. And if you have a good knowledge before, if you have studied this topic before, even without going through all these, by this clue, you can clearly say this is a case of sarcoidosis. Easy one, easy case for you. So the correct answer is D. Sarcoidosis is common granulomatous disease, the etiology of which remains unclear. That's why we call it idiopathic granulomatous disease. It's a diagnosis of exclusion, and mycobacterial, that is acid fast, and fungal, silver stain and PAS are used to rule out infectious etiology. Okay, let's move on. Let's talk about number 4 now. So let's highlight the important point and then you can solve it. A patient presents with a severe form of atopic asthma. Which of the following changes would most likely be found in this patient's blood? Absolutely easy question. Basophilic leukocytosis, eosinophilic leukocytosis, lymphocytosis, monocytosis, or neutrophilic leukocytosis. Any student who has not taken participation in answering this can solve this. Yes, yes, please. Anybody else? Yes. Who want to answer here?
B.
B, sir.
B, sir.
B. Can you give reason why B?
Sir, because of the eosinophil, sir. There will be accumulation of eosinophils due to allergic. When there is allergic reaction, mostly there will be high eosinophils in.
Very
So
good.
that's why, sir.
Very good. Yes, that's the correct answer. That's the correct explanation of the link. Excellent. Excellent, Abdullah. Very good. So this is a case of atopic asthma and clear cut. There is a link. This is allergic condition. So eosinophilic leukocytosis is the correct answer here. But why I have brought this type of cases here so that I can explain something to you. Okay. So what are the situation where there is basophilic leukocytosis, lymphocytosis, monocytosis, and neutrophilia? So let's talk about them. Now see here, please pay attention. The correct answer is B, and every student has picked it correctly. An increased number of eosinophil, also called as eosinophilia, occur in association with several conditions. The most frequent of them are immune-mediated diseases, okay, or allergic disease, you can say, like asthma, hay fever, and pemphigus vulgaris. This pemphigus vulgaris is a dermatological condition. It's a dermatological condition, okay, where there is formation of blisters on the skin. Formation of blisters on the skin. And this is also associated with eosinophilia. And don't forget about parasitic infestation, quite allergic condition. The mechanism of this eosinophilia is because of interleukin 5, which stimulate the differentiation of eosinophilic precursor cell in the bone marrow. Now, every student can answer some of the causes of eosinophilia. Never forget two things: allergic condition and parasitic infestation. I want to add one more there, that is leukemia. Okay, leukemia, especially myeloid type of leukemia like CML, where the myeloid precursor cells are stimulated. What about basophilic leukocytosis here? See this? It is a rare event that is sometimes observed in association with chronic myelogenous leukemia, CML, because basophil is also developing from the myeloid series. Lymphocytosis may result from so many conditions like viral infection, some of the bacterial infection as well, and the names are given here. Brucellosis. Brucellosis is a type of bacterial infection, remember, caused by Brucella. Whooping cough. This is also bacterial infection. What is the causative agent of whooping cough? Yes,
Bordetella pertussis. Bordetella pertussis.
very good. Bordetella pertussis. Bordetella pertussis. Excellent. Okay, don't forget. So this type of quick answer should be given. Hepatitis, mainly caused by hepatotropic viruses. Hepatitis by A, B, C, D, and E. Infectious mononucleosis caused by Epstein-Barr virus, and tuberculosis. Okay, this is also a bacterial infection caused by Mycobacterium tuberculosis. See there? So some of the bacterial infection can also have lymphocytosis. Now, one small clue I like to provide you here. Apart from some exception like brucellosis and whooping cough, many chronic bacterial infection can result in lymphocytosis. Chronic, not the acute one. Apart from some exception, and many viral infection can cause lymphocytosis. Now, this is a bit easy for you. And of course, CLL or chronic lymphocytic leukemia has a large number of lymphocytes circulating on the blood. Now, what about monocytosis now? There is increased number of monocytes which are circulating macrophages. Monocytes are the circulating macrophages in the blood. So chronic infections like tuberculosis, rickettsiosis, and malaria, chronic malaria, and chronic inflammatory conditions like collagen vascular disease and inflammatory bowel disease. Okay, inflammatory bowel disease are the most common underlying causes of monocytosis. So again, think about the chronic conditions here. Whereas neutrophilia or neutrophilic leukocytosis are the cause of acute bacterial infection. Okay, acute bacterial infection. So these are some of the very, very important knowledge for the students. Let's move on. Now, let's go to some other case. This is about Down syndrome. What percentage of Down syndrome patients also have congenital cardiovascular disease? So a bit of difficult question actually. If you know, then only you can answer this. Okay, 0.1%, 3%, 20%, 50%, or 90%. Anyone?
50%.
C,
50%.
Sir, 1/5,
20%.
Okay,
20%.
now yes, different answers are coming. Someone said 50%, someone said 20%. Now, the correct answer is 20%, C. Okay, remember this sentence. 1/5 of Down syndrome child has congenital heart problem. 1/5, that is 20%. Now, which heart problem is the commonest? Which congenital heart disease is the commonest here?
ASD,
ASD,
VSD, and ASD.
endocardial cushion defect with
And ECD too.
Exactly, ASD and VSD. ASD has to be the first, and a type of ASD is also known as ostium primum or endocardial cushion defect. That is the most common in this case. So your answers can be anything. Different textbook mention it differently. So let me write it here. This is endocardial cushion defect. Okay, endocardial cushion defect, also known as ostium primum defect. Ostium primum defect or AV canal formation. Now see this, This AV canal is a atrioventricular canal. The meaning of all these conditions is there is a significant defect, okay, which is there in the atrioventricular septum, which is separating atria from the ventricle. So lower part of the interatrial septum, the atrioventricular septum, and upper part of interventricular septum, all of these are defective here. And usually a small part of the mitral valve is also affected. So this is a major type of problem. Now, apart from this, Down syndrome child has so many other problems. So this is one of the very catchy question in any type of exam. This child has a typical facial appearance, which you all know. This is called mongoloid face. Okay, mongoloid face. Because of this typical appearance, we identify this type of child. Okay, their IQ level is very low. They are usually mentally retarded. And the overall, developmental milestone is delayed in them. They are very sweet type of child. They don't cause a lot of trouble to the parents. They have umbilical hernia. Okay, they have a bit of slanting eye, isn't it? They have simian crease. Okay, and two of the very, very important question which comes from this topic is, when this Down syndrome child survive and becomes adult, near to the age of 40, they develop Alzheimer's disease. Alzheimer's disease is the commonest type of dementia all over the world. So they quickly develop Alzheimer's disease. And one more, they have a high incidence of development of ALL, a type of leukemia. So these are some of the important points regarding Down syndrome. What is the karyotype of Down syndrome? What is the karyotype?
Trisomy 21.
Trisomy 21. Excellent, isn't it? Trisomy 21. Let's not forget the easiest thing here. So there are 3 copies of 21st chromosome in Down syndrome. That's why these are the type of trisomy. See this? So it is clearly written here. The correct answer is C. There's a 20% chance of having congenital cardiovascular disease. Other things I have already explained. Let's go to another case. An 80-year-old man has low back pain. An X-ray of the lower back and pelvis shows sclerotic changes in the lower vertebra and in focal area throughout the pelvis. So sclerotic change means it looks more denser on the X-ray. Okay, it looks more white. The radiologist report states that the sclerotic change may represent osteoarthritis. However, metastatic prostate cancer cannot be excluded. Look at the age of this person, quite old. And in this type of age, prostate cancer is quite common. Which of the following is most cost effective in the initial workup of this patient? Is it bone marrow aspiration and biopsy? Is it digital rectal exam? Is it evaluation of prostate specific antigen, which is known as PSA? Is it radionuclide bone scan? Or is it serum alkaline phosphatase measurement? I welcome some of the students, to answer here. This is a bit of challenging question.
DRE.
Okay. So you are saying digital rectal exam. Okay.
Yes,
Can you explain?
sir.
The patient is having lower back pain and there is also sclerotic changes on vertebra. So these are suggestive of osteoarthritis, but they are suspecting the prostatic cancer. And the most cost effective among these is DRE because it can be done quickly and we can just feel the prostate gland whether it is hard, irregular, or enlarged or not.
Good. Yes, Eunice, you want to say something? Good, Aman.
Yes, sir. Yes, sir. I want mention about the age, which is so much old, like 80s, which is most common suggestive of these options, and with lower back pain, which means that prostate cancer most commonly metastasized to the weight-bearing joints such as hip joint and lower vertebral joints. And other radiological reports state the skeletal changes, which is suggestive of osteoarthritis. Now, the initial workout, they didn't have any DRE examination before. So initial is that, and on DRE examination, we will feel the hard prostate with indentation formation in that, and that is highly suggestive of prostate cancer. And from after that, we can go for other tests such as prostate specific antigens and others.
Good. So both of them have answered this quite correctly. This is a bit of difficult question, but there is one clue given to you, which is the most cost effective in the initial workup of this patient. All others are a bit of expensive type of test. See this, okay? Bone marrow aspiration and biopsy, difficult invasive type of test. Prostate specific antigen, radionuclide bone scan, probably the most cost, the most expensive, I should say. And serum alkaline phosphatase also cost money. Digital rectal exam is your examination. You are not sending to the lab. You are not taking anything from the patient. So that is one clue. This type of questions have certain clues there. That is one point. But another one, the proper explanation they have already given. Age is one of the factor, and this cancer, the prostate cancer, is osteoblastic in nature. So whatever metastasis has occurred to the bone, it leads to bone formation there. So probably that is the reason for sclerotic changes. And digital rectal exam will feel very hard type of prostate, and that will clearly provide us a lot of information, and we can go for other tests later on. We need all these tests actually, but not in the beginning. That was the question asked. The correct answer is digital rectal exam. So we're talking about a case of prostate cancer. So the most cost-effective early investigation in case of prostate cancer is digital rectal exam. Okay, digital rectal exam. Then later on, we need to take help of some other test which were given in the options. Okay? Like we can go for prostate specific antigen or PSA, which may be usually high. This type of situation, but even prostatic hyperplasia, which is common in the older age, can have increased level of PSA. It is clearly written here, and it is a bit of expensive test. Radionuclide bone scan is done to detect metastasis. Okay, to detect metastasis, which is an expensive test, but nevertheless we have to do it later on. And one important information I like to share with you is serum alkaline phosphatase. Now please listen carefully. Whenever our bone is affected, okay, whenever bone is affected, the serum alkaline phosphatase can become high, and the reason for this is osteoblastic activity, not because of osteoclastic activity. This is because of the osteoblast, which has this important enzyme inside the bone. But this enzyme is very non-specific to the bone because so many other tissues are also having it. The important examples are the hepatobiliary system, especially the bile duct. If there is a problem in bile duct, alkaline phosphatase is also high. Okay, even intestine has got alkaline phosphatase, and during pregnancy, even placenta has got it. That's why we need to be really focusing on which type of case is this. Let's move on. Okay, let's talk about question number 7. A 40-year-old woman presents to the emergency department with, please mute yourself, with severe abdominal pain, which is localized to the right upper quadrant. See there, she is a lady, 40-year-old. She presents with abdominal pain. The emergency department. Then abdominal pain is in the right upper quadrant. A urine sample is taken. Now, this is a problem, people are talking here. A urine sample is taken for rapid dipstick reagent strip analysis. A positive result for which of the following substance would most strongly suggest gallstone disease as a possible cause of her abdominal pain? Now, let us diagnose the case first, and then we'll go for the option, okay? See this. This is most probably a case of cholelithiasis. And as a result of that cholelithiasis, some of the gallstone may trickle downwards towards the common bile duct, and because of this, she has severe pain. Who knows? That may be the case here. Okay, so think about that. Now let's go to the option. A, bilirubin, B, glucose, C, nitrite, D, protein, and E, urobilinogen. So what is the correct answer here?
A.
A.
A is bilirubin. Okay, so what type of case is this? Why bilirubin is there in the urine?
Sir, this is a case of obstructive
Hemolysis.
jaundice where the stone from gallbladder dislodge and obstruct the common bile duct, cause extrabiliary cholestasis. So there will be conjugated hyperbilirubinemia, which is water soluble, and finding of these as a dark color urine and clay color stool. So these dark color of urine is because of bilirubin.
Okay, good explanation he has given. Any other student want to speak here? Anybody else? Yes. Do you totally agree with him, or somebody has different opinion? Then only.
Agree.
Yes, agree. Yes, I also completely agree with his explanation also. Okay, it's a very good explanation he has given. So the correct answer is bilirubin. Now, this is a case of obstructive jaundice. Very clear-cut clue is given to you. This is a female, severe abdominal pain in the right upper quadrant. Okay, probably a case of choledocholithiasis. Cholelithiasis leading to choledocholithiasis, leading to obstructive jaundice. This is a case of conjugated hyperbilirubinemia, water-soluble bilirubin, also known as direct bilirubin, which is excreted in the urine. And that bilirubin can be easily detected by the investigation. Okay. At the same time, this patient must be having itching and scratch marks on the skin. Patient may be having, clay colored stool because there is no, urobilinogen, or there is no stercobilin formation. Without that, the natural color of the stool is not there. And this is the reason for clay colored stool. Now, one small question I like to ask, why not E or urobilinogen? Why that is not the correct answer here? Anybody?
Sir, if bilirubin pass from common bile duct to duodenum, so that will appear normally. In this case, bilirubin is not passing it.
That is a very correct explanation. So you should remember where urobilinogen is formed. Urobilinogen is formed in the intestine only when bilirubin is passing there. Okay, in this case, it depends how bad is the obstruction. If it is completely blocked, then no bilirubin is passing, or no bile is flowing into the intestine. No bile is flowing there. So how urobilinogen is formed? But having said that, it depends how severe is the obstruction. Still urobilinogen may be present in the urine, but that is very, very, less important feature for the diagnosis. We don't diagnose diseases by detecting urobilinogen on the urine. Glucose appears in the urine in case of diabetes. That is the most common cause, diabetes mellitus, or sometimes impaired glucose tolerance, or even some conditions where renal threshold for glycosuria is less. Now, nitrite is present in urine in which condition? Nitrite.
UTI.
UTI.
Excellent. It's UTI. Okay, never forget this. Urinary tract infection. It is known as nitrite reduction test. It is very commonly done these days. Protein. No need of any question here. Every student can answer. Renal diseases like nephrotic syndrome, like AGN, chronic renal failure, any other conditions like multiple myeloma. Okay, and urobilinogen we have already covered. Very nice. So this is the way you need to move further. So the correct answer is A. Okay, we have already explained this. So let me move forward. Number 8. A 17-year-old male develops a painless foam mass beneath the nipple of his left breast. So please mute yourself. That's a painless foam mass beneath the nipple of his left breast, and he is quite a young male, 17-year-old. The mass is mobile and no fluid can be expressed from the breast. The right breast is normal to examination. Which of the following conditions does this mass most likely represent? Fibrocystic change, gynecomastia, intraductal papilloma, invasive ductal carcinoma, or invasive lobular carcinoma. One of the easiest case we can ever get. What is the answer?
B.
A.
B.
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 Okay, who said A? Can you explain why A? Anyone? Why A? Or do you want to change your answer now?
So maybe there is a trauma on the chest, so there may be inflammation which causes to a fibrocystic changes.
Okay, that is your explanation, but there is no history of trauma given, right? Yeah. And fibrocystic change doesn't occur like that. Okay, I'll explain that point to you. But nevertheless, okay, he has taken the participation. Now, why B? Anyone? Why B?
Because
Because
sir.
patient is male.
Mhm.
Number one reason, and second is sir, we should exclude the other options like fibrocystic changes. They occur in female because of hormonal changes, and there is also variation with menstrual periods.
Good.
And the intraductal papilloma usually present with bloody discharge, and invasive ductal carcinoma and invasive lobar carcinoma are invasive malignant cancers, and so they should not be mobile, and also this is not the age for these carcinomas. So gynecomastia is very common, and unilateral is more common.
Okay. Yes. He has given the complete explanation here. Very good. Okay. I cannot even pinpoint one faulty point there. So this is a clear-cut case of gynecomastia. This is the exact way gynecomastia present. Remember, this is a quite a common case, and so many of the male, they do not come to the hospital because of shyness, because they are shy that their one of the breast is enlarging in size. They don't want to complain that even to the doctor. It's quite common problem actually, and this is an idiopathic condition. We really do not know why this is happening, but we can point towards the hormonal changes during pubertal time. Probably some hormones, a bit of female hormone actually, the estrogen is a bit more in that body somehow, and that is responsible for gynecomastia. This is more commonly unilateral, but sometimes even bilateral enlargement may be seen. Okay, now there are so many clues given. Mass is mobile, painless. Okay, no fluid can be expressed. According to the age, we can rule out all other conditions here. Fibrocystic changes occur in the female of reproductive age group just before the menstrual period. Okay, it occurs during that time and is a painful condition. It doesn't occur in male. Intraductal papilloma is right. There is some discharge there, but it is clearly given. There is no discharge in this case. And those invasive ductal carcinoma and invasive lobular carcinoma, they are the malignant disorders. They are malignant tumors. Of course, they are more common in female, but nevertheless, They can also occur in male, but those male are older one, not the very young one. Okay, and in male, remember one thing: if breast cancer occur in male, the prognosis is very, very poor than in female, because the mass is the breast tissue is so less there, and by the time they come to the hospital, is already metastasized everywhere. This is a clear-cut case of gynecomastia. Okay, most of the things we have explained. So let's move on. Number 9. Physical examination of a 45-year-old man. See this? This is the age, who looks much older than his stated age, demonstrates thin arms and leg, a swollen abdomen, red tongue, dry, thin, and slightly yellow skin, gynecomastia, testicular atrophy, multiple spider angioma, tremor, yellow discoloration of the sclera, and short-term memory loss. Which of the following conditions is most strongly suggested by this finding? Bronchogenic carcinoma, colon carcinoma, congestive heart failure, glomerulonephritis, or hepatic cirrhosis?
Hepatic cirrhosis.
Hepatic cirrhosis.
E.
I'm sure
E.
now,
E.
okay, there are 53 students who
E,
are
E.
okay, listen, there are 53 students who are participating right now, okay, in this discussion, exactly 53, and all of them, okay, will go for E option here. All of them, if they have attended earlier lectures of mine. We have already taken the extensive discussion about this. This is a clear-cut case of liver cirrhosis. Look at the clues given to you. All these are present in liver cirrhosis. This thin arms and legs because of malnutrition, swollen abdomen, ascites. Why this red tongue is seen? Anybody? Why red tongue?
Glossitis, because of vitamin B complex deficiency.
Sir,
Excellent.
it's alcoholic liver cirrhosis, so that lead to decrease vitamin B,
Very good.
such
Very
as
good.
B1, and that because of that there is red.
Exactly. Okay. That's type of thinking you should develop. That's what I mean by correlation and association in case of medicine. So see this. This is a case of cirrhosis. This is a malnourished patient. This patient ignores diet very badly. They take tea and toast diet. We all know. They ignore vitamins. They ignore minerals. Okay. Then they develop from different vitamin deficiencies like vitamin B complex. So glossitis is very common in them. Even anemia is common in them. Dry, thin, and slightly yellow skin. Gynecomastia. See this? Estrogen is not metabolized because liver is damaged already. That excessive estrogen leads to gynecomastia here. Testicular atrophy, same reason. Multiple spider angioma, very typical features of cirrhosis. Tremor, okay? This is flapping tremor, common in cirrhosis again. Yellow discoloration of sclera is jaundice, and short-term memory loss. Okay. What is the reason for this memory loss?
Hepatic encephalopathy.
Pneumonia.
Yes, say it again.
Hepatic encephalopathy.
Hepatic encephalopathy.
Hepatic encephalopathy, okay, or you can add one more thing there, because of the B1 deficiency.
Korsakoff encephalopathy.
Exactly. Okay, Wernicke's
Wernicke's
encephalopathy
Korsakoff.
and Korsakoff syndrome. You can call it Wernicke-Korsakoff syndrome or encephalopathy as well. Okay, who knows? We are not provided with enough clues there, so we can easily include that as well. Okay, clear-cut case of hepatic cirrhosis. You can go through the other options on your own. Okay, these are very easy here to exclude. Now, question number 10. A young child is brought into the hospital emergency room because he has episodes of vomiting, headache, problems in acquisition of motor skill, cranial nerve dysfunction, and problems in breathing. This combination of syndrome most closely relates to which of the following disorder? Now, let us explain something here before we go to the option. This is a young child. The age is not given, but we believe it's a very young child, brought to the emergency room because he has episodes of vomiting, headache, problems in acquisition of motor skill. This is a developmental delay. Okay, he is not getting those motor skills in time. There is cranial nerve dysfunction as well, and there is problems in the breathing. All of these are pointing towards central nervous system disorder. That is quite clear for everyone. That is the first thing you need to make sure first. Now, look at the option. Okay, which one you think is fitting in all of this description? Cleft palate, hydrocephalus, anencephaly, syringomyelia, and congenital aneurysm. What is the answer?
Cleft.
B. B.
Hydrocephalus.
Okay, it's a B, hydrocephalus. Okay, so
Yes, sir.
most of the students are going for hydrocephalus. Okay, so anybody give me explanation, please?
Sir, the young child
Sir,
with the typical feature of vomiting, headaches, and the breathing problem, which is going toward the triad, and the vomiting and headache, and there is also some cranial nerve dysfunctions due to increased pressure in the increased pressure of the CSF.
Mhm.
Maybe there is increased production of CSF or decreased absorption, but it's highly suggests that the age is young, so maybe there is a malformation of arachnoid villi and granulations, which is responsible for the absorptions of CSF.
So you think this is a case of hydrocephalus? Very good explanation, and you're right. This is a case of hydrocephalus. But let's discuss this in another way. Okay, let's exclude the other causes. Though this is a very easy case, and your approach is absolutely right. Okay, I'm not saying cleft palate is not explaining any of these. So I don't even want to touch that. Anencephaly. Now, does anencephaly present like this? No, because these babies, they do not survive this longer. They quickly die after birth because this is a major type of congenital malformation. Brain is not developed there, though brain stem is there and they can survive for a short period of time. This is not a typical presentation of anencephaly. Syringomyelia is not a disorder of the brain. It is a disorder of spinal cord, where the central canal of the spinal cord is developing into a cyst, and this cyst is expanding laterally. The typical presentation is something else. Okay, it has some gut pain and temperature sensation loss, on both sides. Congenital aneurysm doesn't present like this, a typical case of hydrocephalus. And probably this is a case of congenital hydrocephalus because of young child. See this? The answer is B. The symptoms described are characteristic feature of hydrocephalus. So different mechanism of hydrocephalus are there. It depends which type. Is it communicating or non-communicating? So quite easy case for you. Now, number 11. A baby is born with an inherited autosomal recessive trait in which there is delay in development, resulting in the occurrence of seizure and mental retardation. So this is a baby who is born with autosomal recessive, type of disease or inheritance in the family, and in this disorder there is a delay in development or milestones are delayed, resulting in the occurrence of seizure and mental retardation. The child was diagnosed as having phenylketonuria, so they have already given you the diagnosis as well. The likely defect is tyrosine, tryptophan hydroxylase, dopamine, or phenylalanine hydroxylase? So this is a question from biochemistry. So what is the answer here?
Option E.
E.
So there is no explanation necessary here. If you know, you can answer this. Otherwise, this type of questions are a little bit difficult. But probably I talked about this whenever the term phenylketonuria comes. I always tell my students about the defective enzyme, that is phenylalanine hydroxylase. That enzyme is responsible for conversion of phenylalanine into tyrosine. So when this enzyme is absent, phenylalanine remains as phenylalanine, and it will divert into some abnormal metabolic pathway. Abnormal metabolic pathway. So these are the important point here. And those abnormal metabolites are quite damaging for the brain. So see this, the answer is E. Phenylketonuria results in severe mental retardation and is caused by a defect in the gene that provides the code for phenylalanine hydroxylase. Let's move on. Question number 12. So we are almost toward the end of this discussion. After an individual is admitted to the hospital, it is determined that he displays a variable weakness of cranial nerve and limb muscle, but shows no clinical signs of denervation from the test, which include electromyogram recording. This disorder was partially reversed by the administration of drugs that inhibit acetylcholinesterase. The individual is likely to be suffering from very easy case actually,
Myasthenia gravis.
Myasthenia gravis.
myasthenia gravis. Okay, so why myasthenia gravis? Anybody can give reason for me?
Because sir, here is sir,
Yes.
she is having weakness, and the important one and only option is that the administration of drugs such as inhibition of acetylcholinesterase inhibitor. So
Okay.
it means that there is antibody against the receptor of acetylcholine, and
Oh.
so if you give this drug, so it will replace the antibodies from the receptors, and then
Good.
acetylcholine will work.
Good. Very good explanation. Yes, Khatir, do you know which drugs inhibit acetylcholinesterase enzyme? Which are those drugs?
Sir, there is physostigmine, neostigmine,
Excellent.
hydrostigmine.
Very good. And one drug is used, okay, as a test to diagnose this case.
Endorphin.
Indrophorium. For
Idrophonium. Very good. Idrophonium. Okay. Idrophonium, also known as tensilin. Tensilin is a trade name though, but it is so popular that it is also known as tensilin test. That is idrophonium.
Tensilin test. Yes.
Exactly. So see this. So this type of question can be asked in some other type of problem solving question also. So let me clarify it for other students. This is the person who is admitted with weakness of the cranial nerve, probably weakness of the facial muscle and limb muscle also, but shows no clinical signs of denervation because this is not a case of peripheral neuropathy. That's why no signs of denervation in electromyographic recording. Now, this is a very clear-cut and strong clue. Administration of the drug that inhibit acetylcholinesterase is reversing the problem. This has to be the case of myasthenia gravis. So the answer is C. Multiple sclerosis doesn't present like this. Multiple sclerosis is a type of autoimmune disease, okay, which damages oligodendrocyte in the central nervous system. So there is a patchy type of involvement. Probably optic nerve is affected, okay, and some of the descending or ascending tracts in the spinal cords can also be involved. Amyotrophic lateral sclerosis is a motor neuron disease. Motor neuron disease where both upper motor neuron and lower motor neurons are affected. So you have, the combination of the problem in that patient. Upper motor neuron features are also there. Lower motor neuron features are also there. So we need to really examine the patient well in this case. So the features of upper motor neuron problem are, okay, you all know that if I elicit the tendon jerk, they are exaggerated. But in case of lower motor neuron, they are absent. Babinski sign is a feature of upper motor neuron lesion. Okay, hypotonia or flaccidity is the feature of lower motor neuron, whereas spasticity is a feature of upper motor neuron. So never forget those golden sentences. So muscular dystrophy, it doesn't present like this at all. See this? So for the other students, let me go through this. Myasthenia gravis is an autoimmune disease that causes cranial nerve and limb muscle weakness by producing antibody that act against the nicotinic receptor at the neuromuscular junction. So these are blocking type of antibody. That's why during the treatment process, I need to stimulate, okay, overproduction of acetylcholine, or I should say, I should not allow those acetylcholine to get destroyed quickly. Okay, this is the main mechanism in this case, so that they will, they will be present at an increased concentration at a neuromuscular junction, so that they will displace those antibody and bind themselves. That is the important point here. And these are the drugs which we are talking about. These are called anticholinesterase. The result is that the action of nerve fiber that innervate sclerodermal muscles are affected, producing loss of the effect of acetylcholine at the neuromuscular junction. So this is a myasthenia gravis.